Hi guys, welcome back to the More Than Medics podcast. Today we've got a new episode for you guys after quite some time, because Yasmin and I have had our final med school exams recently, but they're all done now, so we should be back to some hopefully regular podcasts with some new and exciting people. Today we've got Dr. Cat Davison, who's a NATO medical project lead with experience in the RAF as a medical officer, and also in various different global and humanitarian projects across the world. So today was a really nice, cozy chat where she gives a lot of advice and tips on the various different career paths she's engaged with. This episode is also sponsored by PassTest, who have a really lovely team. They really look out for the medic right from before getting into med school to being at med school, and then after for postgraduate exams. Their questions are actually really challenging and help you actually get better at medicine, as opposed to just getting better at sort of pattern recognition, etc. So highly recommend their resources. Use code MTM20 for a 20% discount. But otherwise, we really hope you guys enjoy the episode.
So wonderful to have you, Dr. Cat Davison, onto our podcast. How are you doing today?
I'm very good, thank you. How are you?
I'm good. And you're tuning in from, was it Belgium at the moment?
Correct. Brussels in Belgium.
Nice.
Yes, that's where I am.
Oh, wow.
Lovely. Is that where you're based in terms of work?
That is where, where NATO is. So my current job is based in Brussels. So I'm living the European life.
Love that. Brilliant. Well, I guess talking about your career, you've already started to hint at some of the things that you're doing at the moment. But how would you describe your career at the moment to someone who you've just met?
So I didn't want to be a doctor when I was younger. Okay. I don't know about all of us. We all went in for different reasons. My mother said to me, "Oh, you should do medicine," which meant I automatically went, "No, I don't want to do medicine." And I probably fought it through all my career. I loved science. I love science, did triple science at GCSE, did science at A-level. I wasn't say I was particularly good at it, but I did like people. I wanted to join the Royal Air Force as a pilot. So I went for selection to be a pilot, and I managed to fail the aptitude tests quite spectacularly for being a pilot. So I was sponsored as a navigator. And to be a navigator, essentially what you're doing is you're then directing the plane. So I had a sixth form scholarship and a bursary for the Royal Air Force to go to university. However, I messed up my A-levels. And I will admit, I was school captain, I was doing athletics, I was playing hockey, I was doing everything but doing work. So I had this moment of, oh dear, oh no. And to be fair, I hadn't been completely in love with the idea of doing medicine. I wasn't a natural, but I had this like decision point. You get the A-level results, you'll probably remember. You get them, you open them, and you're like, okay, this is what I was not expecting. What do I do? So what do I do? I was on the way to Birmingham to go and look at geology through clearing, very random, and I crashed my mum's car. So literally, it was like, okay, A-levels haven't gone well. Crashed my mum's car. She was not happy. It was a brown Nova. You probably won't remember Nova. It was a horrific car. No. So I had to come back with the map, the radio, on the train. Didn't make it to clearing. Didn't make it to see Birmingham. And that's when I kind of had it, okay, what are you doing here? And I think for all of us in life, especially all your listeners probably have all made into medicine, but you may have others that haven't. And it is perseverance, and it is, if you want it, I think you can get it. To be fair, I did a retake year. I worked my socks off, got my A-levels, and got into Liverpool I was a house full of retakers we were. But I think that what I'm saying is that if you want it, you can get it. It's not a case of try it and then give up. So that's it. So that's how I got into Liverpool. But on the back of that, obviously, I was sponsored by the Royal Air Force. I'd been a cadet. And so, yes, that's how I ended up in the Royal Air Force and sponsored and paid through university.
Okay. So how did that work then? How did they sponsor you? And why?
So as a sixth form scholarship, you get a a trip to Grantown-on-Spey, and you get a little bit of money. Then you got a bursary for 2 years, my first 2 years of medical school. Then I got a cadetship for 3 years. So I got paid a salary. I was a pilot officer in the Royal Air Force, and I was paid money through university.
Whilst at medical school?
Whilst at med school, yeah. So
did you... Sorry, go on.
No.
Did you do some... So you did some work with the RAF whilst you were at med school as well?
Yeah, you joined the University Air Squadron. You were required to become a member at the time when I was going through. They taught you to do some basic flying. Realised how bad I was at flying. There was an absolute, it was right. And I'm not a surgeon either. I knew my hand-eye coordination was pretty poor. But for, so you literally, they sponsor you through, and you meet up once a year. And that's it. And so 2 years of bursary, then a cadetship. So there was an interview in between. But the idea being that when you graduate, you go and do your house officer jobs. I think for you, it's the FY1 and FY2. And then you join the military. So.
Oh, wow. So it's like a full-on kind of plan in place to get you set into the RAF.
It is, but also it's kind of to get talent. Because we know that going to medical school is expensive. And like you, I had the student loans. I was the student loan era. It's not easy. It's not easy. So sometimes the ability to actually be sponsored, it takes that pressure. It really takes the pressure off. What did it mean for my undergraduate? It meant I went flying. I had a club, this University Air Squadron I went to every week when I was at Liverpool. You know, I trundled up to Southport to go to RAF Wood Vale, and we had the town nights were actually in town in Liverpool. So that was on a Wednesday night. So there's a community. You were joining people were sponsored to be pilots. They were sponsored to be engineers. They were sponsored to be logisticians. So you were all in it together. Quite a nice team when not doing medicine. So you had almost like a mix, which was lovely.
Yeah,
really lovely. Yeah.
I guess also in Liverpool as well. I'm actually from Liverpool originally. So, and I actually used to do the Navy. So I know they have quite a lot of kind of support for cadets in general, whether it's Army cadets, Navy cadets. It's quite a big community there. So I guess during med school, were there any other requirements that you had to do to kind of continue the scholarship?
No, I had to pass your exams. I'd learned after my A-levels. To be fair, I mean, I didn't fail them, actually. I just didn't get what I wanted. No, they didn't. They expected commitment to go to the University Air Squadron. The commitment, ultimately, it's you have to pass your studies because they want you to come in. They want you to finish qualify as a doctor and then go to initial officer training. So obviously in the Army, that would be Sandhurst, but for being Royal Air Force, it was RAF College Cranwell. So they want you, and you join your cohort, and to be fair, I will tell you, I have friends that I made from my beginning of medical school that I'm still with friends today. And so this weekend we're having a reunion. So all those, and we've all joined the Air Force, and we've all left the Air Force, and we're all still connected. It's a really lovely group because there is a common denominator, but you're not all the same. Like one's a space doctor, Dr. Pete Hoddy. He does space. He's at King's College London doing space. He's a space professor. Then you've got Kieran. She was a GP like I was, but she did public health. So she worked into the global setting. You got me as a GP. So I think for all of you going through medicine, what you start off to do doesn't mean you'll end up doing it in 20. Because I'm 45, so I'm probably got 20 years on you, and it probably the difference will be and you'll all and tell, please, whatever you do, stay friends with people that you go through training, qualify with, and then support each other because we've all just had our 20-year reunions last year from medical school, which was really good fun.
So lots of reunions then. That's really nice.
Lots of reunions. Yeah.
No, I really like how you had that community in there, and I'm sure that's the same now in like OTCs and is it called RAF or ORAF or
it's called the Royal Air Force
universities,
and it's the University Air Squadrons, it's the ERNU for the Navy, and then it's the OTC for the Army.
Yeah. No, that's really nice. And just coming back to what you said earlier, I think people who go through the trials and tribulations of retaking exams or reapplying to med school or coming in as a postgrad, they just seem to be the best medics in the end. They're so driven.
So I,
That they've got
yeah,
that fire in the belly.
I mean,
Uh,
my father died so my father died. He was ill, but he died 4 weeks before my medical finals. And I will tell you, I would not have passed my finals had I not understood the anguish and pain of failing. Not failing, but not getting what you want. Does that make sense?
Yeah.
I call it failure. It's not failure because, to be fair, it would have got me to do geology at Birmingham. But the bit I think is, I always said, when my dad died, I mean, he was ill for a long time, but I still worked through it. I knew what I had to do to get through the exams. And I think for anybody that is struggling, I mean, what can I talk about that being at med school? It's a tough time. I know you'll probably have colleagues and friends whose parents are ill, families members ill, and it's never easy. And, you know, there's a part of me that says, wish I'd taken a year off, but I was so stubborn to not be able to graduate with your contemporaries, your colleagues, your friends, and to do that extra year. It felt like a lifetime. So I, you know, pushed through to do them, and it was lovely. One of my friends at university, she went to the cinema with me on results day, because you'll have it. The results will come out, and you'll be like, and we went to cinema. I said, I don't want to know, I don't want to look, I don't want to see. And I was lucky, I passed. But I always attribute to understand how much hard work you have to do from that retake. Those exams of realising the sheer volume of work you had to do to get through. Because we've all got colleagues that are super bright, don't work at it, you know, lazy, bright and amazing. And there's always all of us that can't. We've got different skills.
Yeah.
So anyway,
There's
no,
the
I guess it's
discipline
about,
that keeps that transcends.
it
You know,
does.
if you're born intelligent or born with a slightly different skill set, I think that discipline, that hard work, and that grit
Exactly, and you'll
gets you
know the
through.
ones that I like what you say. You about the ones that make the ones that have understood hardship, or the ones that have had to retake and make the best medics. I also, we're not all let's be realistic. We're not all conventional to standard teaching. Like, not all of us are the best at doing writing essays or exams, and you know, I've learned that in time, and you will learn it. Where does your skill set lie? You know.
Yeah.
I mean, have you both decided what you want to do when you graduate? Have you decided what speciality you want to do?
I've narrowed down the list, but
Okay.
still unsure. I'm deciding between emergency medicine, GP, pediatrics, or obs and gynae, but basically very broad specialties, because I know for myself, I'm not a person who can go in depth. I don't have that concentration to go in depth in one area. I need to like keep myself entertained in lots of different things. So for me, those areas are what I'm most interested in, and I like kind of the fast pacedness of them all. But
Brilliant.
I'm also trying to keep an open mind and just like have a more, not a linear career, because like you said earlier, actually, how you said, like, you know, you 20 years ago wouldn't have thought that you'd have this career that you have now, because it's so different. I think that's exactly my kind of perspective. Like, I know that my career, me in 20 years time, I'm not going to expect what I've gone through, basically, because medicine is not that linear, and I think that's the beauty of it. Like, you can do so much within healthcare, but it's just not really promoted realistically. And I think, coming back to what you're mentioning, ultimately all those kind of failures, what we call them, helps develop your resilience ultimately.
Yes, that's a
and
very
helps you
nice way.
flourish.
How about you, Martin? Do you know what you want to?
I think I'm more of a generalist than a specialist as well, same as Yaz. I think we're very similar in that way.
Yeah.
I don't know. You know what I am interested in? Humanitarian medicine. What is that? How does one get involved? And I guess I'm talking to the right person. So
So I think go back to you're going to qualify. I mean, going back, you're going to graduate. Okay, you're going to do your FY1, FY2, and I do think you guys you have it harder than we did, because we could experiment, we could play, we could try a couple of years of surgery, we could do a bit of emergency medicine, then we could knot it together into a training program, and it would count. Okay. I to be fair, I was like you both. My dad had died. I was pretty exhausted, and I chose GP, partly because it was less taxing on the brain, but also because as a generalist, GP opens the doors to so much. And I tell you what, at the 20-year reunion, The people you realise that became GPs that spent their entire undergraduate saying, I'm going to be a surgeon, and there they were as a GP. So it's an excellent it's an excellent leveler in a sense that everyone what they start out and what they become changes. So how about humanitarian? How do you jump into humanitarian medicine? So the key is the basis of what you want to base it on, and the best way is always being through public health. Health. I personally wanted to get to be an independent practitioner as quickly as possible, so that's why I got through a GP, got it done, and then you're on the register and you're an independent. And to anybody I talk to, mentor, advise, if they're very close to the top, I say just get it, because there's a tipping point when people are exhausted, they're fed up, they're doing hospital medicine. GP, you do hospital medicine, they're doing the placements, they're not enjoying it, they're not there. Get that independent practitioner status, because then that opens up doors. You can be independent. You can then, if you want to do expedition medicine, you can do expedition. If you want to then go off and work globally, you have a qualification. Now, that's not to say United Nations doesn't take you without a UK independent practitioner status. They do. But it opens doors to go and do exams in America. It opens doors. And if you're that close, obviously if you're at the beginning and you decide medicine's not for you and you want to go and find another route. But I really feel for those that have just close, get it. Get it. So public health, public health masters, public health formal training. It's interesting. Most of the organizations, there's two ways you do it. You either look at going through the Médecins Sans Frontières into the NGO route, the support. And what are you actually doing? Well, there's a number of ways you're looking at it. You're either supporting the mission out there, and to be fair, it is experience that you're doing, and they will want independent practitioners too. Okay, so if you're going to go with Médecins Sans Frontières, or you're going to go and work with IOM, and they're going to want doctors who are independent to work on their own. So that kind of links back to the point about getting yourself as a qualified in something. Now, of course, if you're a surgeon, you're going to become an elder medical surgeon, then you can jump off. The key for all of you is you're going to be qualified in something, and I know you're looking down the barrel of potentially doing it for 20, 30, 40 years. And I know for some that's quite, oh my word, that's a long time. So how do you have fun on the route? And there's a bit of me that always asks, are you about to be or to do? Are you about the journey, or are you about the end game? What is it? You've always got friends that want to be a max fac surgeon. That's what's been their aim in life. Or you've got others that want to just meander. Both are equally. So what about humanitarian medicine?
So what would you say? So whilst you're developing that expertise to become a practitioner in your own right, what would you advise people to do in the meantime to give themselves the best possible chance of excelling in that field?
So I would
gain public health, whether it be
so I would gain experience of working outside clinical medicine. So I would be expeditions, group trips, being the doctor. There are a lot of organizations that need doctors. I would do things like World Extreme Medicine. I would go to their conferences. I would gain an understanding of what does medicine outside hospital, outside the four walls in an industrial environment mean. You've both got your electives. Your electives are going to be exactly that. It's the first taste of working in different environments. And test yourself, because we're not all suited to operating in different environments. So actually going out as the doctor, there's volunteer work. I think I'll send you some links at the end of this, things that always want doctors. You're always in demand as a doctor, and you don't have to be the completely independent qualified one to do these kind of activities. So I would get out there and I would test your skills in environments. So what does that mean? Well, the first time you go out, you have your kit, And then you always go somewhere and you wish you had more kit, or you wish you had different kit. So you learn very quickly, what kit do you need? 2, you learn about evacuation plans. You know about operating in high-risk areas with not a lovely, comfy hospital. And you learn all about what do you do if something happens. And it's all about testing. It goes back to your point, Yasmin, about testing yourself under pressure, the resilience. How resilient are you? Can you cope? Because things do go wrong, and the ability to overcome them. So I think we should be anybody that's interested in doing medicine outside the hospital, in, let's say, a different work, needs to go and try it.
Have you
So-
been on any expeditions
Yeah,
that you
yeah,
can
I
kind of
took-
talk through, like any reflections from those expeditions or kind of key learnings?
So I say to all of you, whenever you do anything for anybody, write a report, okay? Doesn't matter if they ask for one or not, I always write a report. Why do you do that? Because it helps summarize your thoughts. So I took up, back in 2013, I took up London Business School. They were on the executive MBA up Kilimanjaro. Okay, I was taking them up. Those 2 of us taking them up. It was I can't remember the name of the company I was doing it for, but essentially had all the kit. I had never done high altitude before, so for me to go up, it was also a bit risky. But we were doing the longer route up, so you can acclimatize. I had the right medication. I had the right kit. What will I say about that trip? I knew there was things that probably I'd have preferred to have had. I knew things I know they should have for future taken. Basics. So I wrote them a report, and everything, whenever I've deployed anywhere, whether in a military or on an expedition, I've always written back to management a report, very polite, factually based. But what you're essentially doing is you're gathering your thoughts, you're helping whoever becomes behind you. You're looking like a good professional team player. You're looking like you know what you're doing. And what they mean, if they need someone again, they think, oh, actually, Yasmin, yeah, she was really professional. She wrote a report. She had they'll call you back. People, they want to work with people they know they can trust, they can like. So if you see people always getting the expeditions, it's probably because they do a good job, they support. And we all know that when you have the disorganized medic who's not on top of it, all over the place, kit everywhere, can't cope, they're not going to be asked again. But you do have to cut your teeth on something, because I will tell you, when you're going on a mountain, even if it's some of the other things I did was London to Brighton. There was I think it was a walk, and I was looking after area, so I did all of everyone's feet. I spent the entire day doing blisters. But what did you learn? You learn how to do blisters, but you also know how to spot heat stroke. You know how to spot those that were struggling. You knew when to say, I think you do this. So you're now doing medicine in a school hall or on a route in a tent. You're having to do the basics, but you're doing it out the environment that you're used to in. You haven't got anybody to call on you. You're on your own. That is where you really learn. That is it.
Yeah, and I guess that also then just strengthens your clinical understanding and your knowledge, because I think a lot of the times, even like I'm just thinking about our teaching in medical school, the first thing we're taught, okay, once someone comes with, present a complaint and you take a bit of a history, okay, go straight to the investigations, take the bloods, take this. But realistically, when you're deployed for like a defense kind of expedition or like, extreme areas, you won't have that kit available to like, let me just check the bloods and the CT scan to figure out what's going on. You just have to react based on your clinical judgment. And I guess those kind of skills strengthen that even further. And actually writing those reports allow you to reflect as well on those experiences. So then you improve for next time on an individual level.
And I'll also say, so a lot of people say, oh, can I go out with X organization and Y? I'll tell you now, you need to investigate the organization you're going with, because they are in charge of your safety. Okay. So let's say you're going out, let's say take, for example, Gaza. Okay. Let's say you wanted to go to Gaza and work part of an organization. There are multiple organizations that are there, and they'll probably see more that will get involved. But you have to understand, when you meet them, how professional are they? When you talk about your travel plans, are they on top of it? When they talk about if things go wrong, there's a real responsibility to take responsibility for yourself, because if you become a problem, you can't deliver what you're there to do. So the biggest one for me as the medical staff is to be as professional and not become that burden. So be very careful with what you choose. And it's the same for expeditions. There was one particular race in an environment that I was asked to doctor on it, and I looked at the whole plans and went, no, it's too risky. Because the evacuation lines out were really, really long. The comms were difficult because it was secondary jungle. Everything about it didn't feel right. So the other part for all of you is, if you think it doesn't feel right, don't do it. So really look at the organization, look at how they treat you, look at how they treat others, look at how supportive they are. If they want to skimp and save and say, no, we've got no money for kits, we've got none of this, we can't, you then do have a few more alarm bells, because you want somebody that is going to take the risk seriously. You're there to do a job, but you have to feel comfortable. And there's a lot of mentoring I do with just taking someone through the basic checklist to prep for an expedition. There's a very standard way that you look at it and how you prep, because you need everything from emergency numbers, actions on. I do actions on if you are having the basic fundamentals. So heat illness, basic feet. Okay, everyone's feet. Have you got enough to look after the basic first aid?
What are actions on? Sorry.
Actions on, essentially, what I do in that incident. So let's say you suddenly got chest pain. What are my actions on to support you? It's a very military term. So what would I do for you if you were, I don't know, let's say 50 miles from anywhere in the middle, and you suddenly got chest pain? What would I do with you? And so it's all about the immediacy of immediate care, but also at the same time planning how I'm going to get you out, what I'm going to do with you, or am I going to let you continue? You sometimes find on mountains that I had one when I was up Killy. I was going up. I was asked to look after an individual in another group. He was struggling, and I said, no, he's got to go down. Can't go up. Really struggling. And he wanted me to go on camera to tell him that I'd told him he couldn't continue. He was a brilliant American guy, and I said, look, I'm not going to go on camera. Just get down. Just get polo far. No, well, slowly polo, but essentially go. Just get down that mountain now. So,
Gosh, it seems like a lot of the tasks which you do are before the expedition itself, right? A lot of planning like that is. I wanted to ask, like, you alluded to obviously a few of them, but what are the main things you do? We had a talk from an expedition medic. It was our first talk, actually, wasn't it, Yaz? On our sort of More Than Medics Monday series. And you're saying 90 odd % of the time you're not doing medical things. You're just part of the team. And you have the potential to be activated, I guess. Is that close to truth?
Absolutely. So I'm really careful. So first of all, is the group you're with. Okay, you'll be surprised at how many people lie and don't tell you that they've actually got medical issues, and they forget because it's normal to them. So for example, if I take this group, I'm taking up Killy. Okay, they had some.
I love how you call it Killy.
Yeah.
Continue.
Killy, but they all had medicals. Okay, they all have medicals, and then it was agreed on confidentiality. They released it to myself so I could go through the medicals. They all had ECGs. Now, not all places do that. So they've got ECGs. And then you get the doctors, you don't sign it, the doctors sign off saying they're happy. Then you went through, have you got any high risk? So the key one is the high risk. So a lot of what you do is before you go with them. And you also ask them, and you also put down their BMI and their height, because you do want to know how essentially people's tolerance is different to what you're going to do. So to understand some people, and it's not, are they overweight? It's no issue, but can they be fit and overweight? Of course they can. So it's just working out what you're doing and checking the individuals prior. And it's all about what kit you're going to have. So the next thing is, what are the biggest risks where you're going? So you'd have had this. So if you're going somewhere hot, what's the temperature? Are you going to be moving in the day? Have you got a time limit? Then you look at where you're going. So evacuation lines, what support have I got? Have I got helicopter cover? Have I got ground cover? What's the furthest part when I'm furthest from anybody? Then you're into communication. What radios have I got? Who's looking after it? The key for me is, don't rely on everyone else. Ask about it before you go. And it's a lot easier sitting in the UK to talk about it than suddenly arrive and going, I don't know. And of course, what we do a lot of is, we go off really fast. In the military, we went off very fast. So we'd have bags packed, ready to
Yeah.
go, you know. Yeah. Anyway,
Yeah,
sorry.
I wanted to ask them the difference when it comes to your military expeditions. How do they differ from your kind of typical expeditions? Like how does the RAF medical officer role differ?
So this bunch of executive MBA students, these are the most bright people in the country. We had to get them up 10 minutes early because they never were up on time. They were never ready on time. They were never ready to go. So we used to get them up. We used to get them out the door 10 minutes before we had to go, because the natural is that when you put a human outside the normal habitat, tired, emotional, slightly, your altitude, all the
Yeah.
normal coping
They're
mechanisms
not
go
on
out the
Excel
window.
spreadsheets anymore. Yeah.
No, exactly.
Yeah.
And they're all like, they're not sleeping great, so the bags everywhere, complete tip. I call it administration of life. Okay, to administer, you have to obviously eat before you go, water, fluids, basic sleep, because ultimately you're trekking up a mountain and you have to maintain the fundamentals. And unfortunately, they go out the window. So what is it with the military? The military, we obviously train quite hard as well. So for the military guys, and you're all pretty much aware of the same kind of things. So you all brief the same way, you understand things the
Yeah.
same way. You are trained in a way that you train to be potentially leader, but also how to follow, if that makes sense. You're trained in it's a teamwork an element. And generally most people you go with, you do know each other. I think it was a brilliant opportunity to see those London Business School up that mountain, and they would have learned a huge amount about themselves, each other. But yeah, 5 minutes before 5 minutes, we used to call it, get them up. Even on the final summit day, they were late. Jeez. Yeah. Anyway.
Nice. Yeah, I think there's a lot of it seems like there's a lot of similarities between humanitarian medicine and then military medicine, because you're planning for different crises, you're thinking about, you're mapping the land, charting a course, all of these things. I was wondering if we could switch gears and talk about your experience in the military, in the RAF. What was your experience like joining initially, as a new doctor, as a new officer? What was the life like? What sort of things did you get up to?
So to be fair, it's like you guys, you'd have finished your FY2, you'd have done 2 hard years, although to be fair, I did 1, and all of a sudden you've got 6 weeks of fun. And I say fun, yes, you've got room inspections, yes, you've got uniform, you've got a lot of ironing, and there's a lot of discipline, but you're spending time on the mountain with colleagues, you're learning to map read, you're doing exercise, you're learning teamwork, you're learning how to lead, you're learning these whole new skills. And you'd have just spent 2 years doing medicine, being incredibly responsible. Now all you're responsible is for yourself. So it was a wonderful experience of you as I said, you make the best friendships because you are sleep deprived. You're overnighting in this, or you're on exercise, and you're pretending, okay, that you're on a patrol. All of these exercises that you're doing, and they're the fundamental. We don't get much, we didn't when I was young, get much leadership training within medicine. I think you learn how to be a good part of a team, you learn to get on with everybody, but you were never taught the fundamental basics about management, leadership. And I loved it. I think it was a really brilliant, and to be fair, I was then a junior doctor in the military, general duty medical officer. I think I went skiing. I think we went skiing. I think we had fun. We did a bit of primary healthcare, but it wasn't arduous when I went through for that initial 3, I think it was the final 3 months. And you're wearing uniform. There's a sense of belonging. There's a sense of being part of something. And I can tell you, I think through my entire Royal Air Force career, I had a lot of fun. I go back to the point about picking a course. Yes, I did GP, but I got to deploy some brilliant places. Yes, I did Afghanistan in Bastion Hospital, but I also did South Sudan with the United Nations. I went off different parts of Africa. I took a small team, because you've got to remember, a doctor, what you do as a doctor is they send you because you can extend out evacuation timelines. So some of the toughest parts in the world where you can't get someone out there, let's say for 6, 12, 18, 24 hours, you can send a doctor in to essentially look after the team to prolong field care, extend the time. And when you're looking at likelihood versus impact, you look at what a doctor can give you, the skills. I'm just talking, I was a GP, so I can't crack a chest. I can't, I wasn't intubator trained. Yes, I could, RSI trained. I could intubate, but I was only basic. But the skills I had were all about basic CABC that I could then stabilize someone, the basics, and then do a little bit of prolonged field care. But it was a GP skill. It was pre-hospital care, basic GP. It was not top notch, HEMS level. But that was enough. And also your skills. You realize as a doctor, your skills to be able to deal with anything. I mean, if someone got DNV, okay, doctor, yes, I could give antibiotic. Yes, I could have sent them off with antibiotic, but monitoring them, iron them, do they need to go to hospital? Ultimately, what you care about with anything you do is, are they big sick or small sick? Okay, that's the only decision when you're out, big sick or small sick. Big sick, I need to get them out of Dodge, and I need to get them out, and I need to get them somewhere. Small sick,
Out of Dodge.
Out of Dodge, we used to call it. Out of Dodge. Out of
Okay.
Dodge.
Out of danger.
Out of danger.
Okay, fine.
Out of Dodge.
Fine.
Out of danger.
Love that.
I get them out. Are you big sick or small sick? So if you're big sick, I need to get you out now. If you're small sick, I've got time. And that was always for me a decision point of, okay, you're big sick or small. Of course, small sick can develop into big sick, but you can work with that. You have time. But you're big sick, you're into. So doctors within the environment operate and go anywhere. And I think if anybody has an opportunity, even be reserves, I mean, that's what I was going to say. If anybody wants to do their and join the reserves at some point, there is so much out there, fun things to be had.
What is the reserves?
So
can you expand on that?
Of course I can. So the UK military, all three have reserves. So in other words, they're people like yourselves, let's say, that qualify as doctors that work in the National Health Service. You become a reserve doctor. And if there is an opportunity for you to go out globally and do something, then you get deployed, and what happens essentially is they pay your wage. They essentially, and the National Health Service will backfill you because it's agreed that they will allow you to go and to do your military service. It happens across most businesses everywhere that if someone is in the reserves and they want to go, let's say, to Afghanistan for 3 months, you plan it way in advance, but then there is a that you can go, and then the military essentially pay your wage, and it's a reciprocal agreement. So it's a way of essentially it has a commitment, I think, of about 21 to 32 days a year, which is not much when you add up the weekends. But they're always looking for doctors. There's always opportunities in the doctors to do it, and you can choose what you're interested in. So if you enjoy being at sea, you can join the Navy opportunity. Some people like the Marine because they like being land-based, but they also like the fact it's essentially in a maritime setting. You can choose the Army, and there's loads of roles. So I have a lot of friends that didn't want to do the military full-time, wanted the freedom, but wanted the opportunity to dip in and out. So
I see.
Right.
That's a really cool opportunity. Actually, I had never, because I always thought you had to do it full time. So that's great, actually, to hear that actually they have that option, that flexibility, where you can actually get involved, but also keep your NHS work on the side.
Yeah. How often do they get, like, on average, called out?
So you plan it.
A reserve.
You plan it. So you plan it. So your commitment
So
is
you plan it in advance.
Yeah, 100%.
Okay. Okay. I thought it's like, oh, we need you, and like you just will get you on the next plane out. Okay,
no,
fine.
there's not. But I mean,
Right.
you obviously can go on some on-call rotas, but it's all predefined. So if you turn around and say,
Okay.
I want to be on the rota for, I don't know, let's say a role 2 a role to afloat, let's say, that's potentially going to be on call for this 3 months, then as a reservist, you can be on that rota, but obviously it all gets cleared between your work. The National Health Service is very good at supporting people in reserve service. And there is agreements with, there's a covenant, the military covenant, which means companies sign up, but there is a real understanding, and it's an agreement between essentially your employer and the military. But some people I've got colleagues that have essentially done back-to-back reserve tours, essentially as if they're full-time, but they're still a reservist. So it's a nice flexibility to if you have a sense of you want to do something a bit different or try it. There's a lot of people that have tried it before they come in full-time, and because it's not for everybody. The military isn't for everybody, but some people like to push themselves, do something a bit different. Try.
What are the main sort of what are the main sort of things that you've noticed in people that have gone on to love the army, the military, and stuck on with it, and it was really their bag of worms, as opposed to the people that maybe thought they did, but in the end it didn't quite materialize. It didn't click with them. What sort of personalities or types of people do you think?
So I don't think you can.
Military's cut out
I don't think you can, because I think you're always surprised. Okay, you're always surprised. So I'll tell you, families take a prominence in people's lives, and you'll be the same. Okay, you will literally want a family, get married, have children, and when you have children, the game changes. You know, the idea of going away for 3 months when you're like in your 20s, woo! Idea of doing it when you're 30s, you're like, no, my child won't remember me. And it is a real difficulty, and it works for both parents. Both I've had numerous friends who are parents, be it male or female. That pull of going away when they're children is really, really difficult. Just to be fair, the pull of when you are probably on call. Yasmin, you're doing emergency medicine and you're on call for the 3rd weekend in a row, or you're covering, and you'll be like, oh, why didn't I choose GP? We do not know what we decide now, and that's why I think I would love to give you guys back the flexibility that we had when we went through, to allow you to try 3 years of emergency medicine, but it count towards something. Does that make sense? Because I think my colleagues that tried everything were some of the best colleagues, because they understood the basics behind surgery. They understood when you're in ER. I could call the colleague who'd done surgery because he knew what it was the Rick's tapestry. It was brilliant.
It's really tough, like talking to friends who are F2. They don't know what they want to do, because they're like, okay, I like ophthalmology, but I've actually never really had more than a week in ophthalmology, and that's just a massive shame, because oftentimes they just like, okay, this is a bit of a risk, it's quite competitive, I'm just going to back down maybe, and it's a shame that like you don't get to try what you want to do for the rest of your life.
But I also competitive with you guys as well, though. I think the competitiveness. I mean, if you are thinking of humanitarian, the other one is the DipTrop Med, Diploma in Tropical Medicine. That's always Liverpool, London.
So many people have done that. Who are like, is that just like a rite of passage? Is that?
Yeah, I mean, I didn't. I never did it. I wasn't that into it. But those that want to go and work. If you want to go and work WHO, or you want to go and work out in agencies in Africa, it's a very good baselining. You can go into it different ways. I mean, I'll be honest, I was not particularly academic. I wasn't someone, I don't have papers, and you've probably all got colleagues, probably even now as medical, that are probably doing papers. I wasn't, but I was more a practical person that really enjoyed doing medicine in difficult places. And then the bit I have loved is the organizational side and the managing and leading others. So being like a regional medical director, having medical facilities all over, and how do you bring together a global workforce? Because I will tell you, the cultural, it's brilliant. You can have the culture from everybody's trained in different places. everybody is trained in different ways, and you pull them together, your common denominator is the patient, and it's patient safety. And so how do you pull together different cultures to almost deliver very much how we do in a no blame culture, governance culture? Yeah, and that's the bit I love, actually, is learning from other cultures and other doctors.
So kind of then linking into those kind of roles, how did you get into those then organizational based roles?
So as I said, I sped through to be a GP, and then I got into leadership, and I really enjoyed the leadership roles. I wasn't a natural lover of clinical medicine. I mean, I will tell you, it's a difficult tick to give up. So at the moment, I am what you call a doctor in leadership. So under the revalidation, which you will all do, I'm a GP on the register. I am still a qualified GP. But if I was to go back to do clinical medicine, I'd do a 6-month return to practice. I would get my tick back. But right now, I'm in a leadership role. So I touch medicine, I do the leadership, the management, but I'm not. So for all of you, and the key I want to say to all of you is that there is this view, some people's views, I can't take a break. I can't take a break. Whether it's maternity, whether it's paternity, whether it's a death, of course you can take a break. The system has to allow it. But the key for you is if you suddenly turn around and said, I want to do 3 years and go and do something completely different, you can come back. The assumption is you haven't. You are UK trained. You can come back into the system. So I do say to people, and I'm hoping this is still the same as it was, but when I used to talk to my appraiser for the appraisal, and be like, of course you can always come back. But we always have this, you will have been on this treadmill. You did your A-levels. You did your medical degree. You became a doctor. You'll then race through to get to the top, and you'll come off the top. And sometimes you'll have friends they took a year out and went to Australia, or they went off and did, I don't know, let's say UNV. Let's say they went to United Nations as a volunteer, and they worked in South Sudan for a year. At the end of the day, it doesn't matter, if that makes sense. And a lot of your cohort, I suspect, will jump into other options as well, because medicine is a phenomenal degree to start with. So
yeah, no, it's amazing. There is so much that can be done. I wanted to ask, so you started obviously in the RAF as a medical officer, I guess at the bottom of the pecking order, so to speak. And then you rose the ranks, or literally rose the ranks in this case. I use that analogy in other areas, but you literally did. And so you were sort of at the helm of the tactical medical wing, if I've got that correct. So what was the sort of difference there in terms of from the start and then there at that level? What sort of activities do you do? What responsibilities do you have?
So I'll say to anybody, you have to earn trust. Okay, you have to earn your team respect and trust. There's an assumption that because you're the leader, you get it, and you don't. So I had 160 workforce of varying from doctors. I had logisticians who looked after the sort of supplies. I had movers that got everything ready to go out the door. I had drivers. You had everybody, a complete cohort. And the one thing I learned from that is they are more important than you. And that is the key fundamental, because you can spend all your time looking up yes sir no, and looking up to do it, but they are the driving force before. And if you don't look after them, then when you have a difficult time, they don't look after you. And one of the keyest learnings I always said is get to know your team. So the most important morning for me was the Friday morning walk around. So I used to Friday morning go and see everybody. Okay. I got more information on my walk around than I got from any of my senior leadership team. So the ability to walk around and talk to people, build those relations, ask how their daughter is, get to know them, because people will very quickly tell you if they're not happy, what's going on. And it builds a trust. There can be a number of layers of hierarchy. So when you are a consultant and when you are in charge of a hospital and you're moving through the ranks, talk to everybody, keep talking to the team. You'll remember as a junior doctor, you'll get to know the nursing staff, you'll get to know the porters, you'll get to know the cleaners, you'll get to know the canteen staff, you get to know everybody. Talk to them all, and be part of that team. And I think the key is we forget that just saying hello to somebody and how are you, asking how they are, is really, really important. We all have bad days. We're all upset, and we've all had where we're heads down. So for me, that point was about, I had a unit that was on standby. It was on high readiness. So I had people that could go out the door at 6 hours notice. They were tired. They were busy. You never knew. And you have to, you have to build in the resilience, the resilient word again, Yasmin. You have to build that in to allow them that when something goes off, they will go and they're not exhausted. So I didn't care for presenteeism. I didn't care if people weren't in work, providing they were working. I did, and this is before COVID. So if they finished their work, they could go home, because what I did know is when something happened, they would be in all day and all night. So it's creating that, we call it presenteeism. It's trusting people. And the one thing I also did is I allow people to do some career courses. If there's one thing I say to everybody is, you don't have to know exactly where you're heading, but you do need a heading. So of course you can just meander in life, and that is not an issue. But like the guys, I mean, at the moment in NATO, I'm working with some phenomenal master's graduates, and you know, their international relations phenomenal degrees, super bright, and it's like, where are you heading? What's your I used to call it the 1 year, 3 year, 5 year plan. So where do you want to be in a year? Where do you want to be in 3 years? Where do you want to be in 5? And at least have an idea. So if you are thinking about doing, I don't know, humanitarian medicine, you think, actually, I'm going to, let's say it's your stage, I fancy doing public health, I fancy going into that realm. Well, start reading about it. Start reading articles on it. Start reading up about stuff. Start understanding. Is it something, can you cope living with no shower, where you have to keep your mouth shut, where you can't drink any water apart from bottled water, and there's E. coli in the water, and you're constantly dirty because of the dust? Some people won't like it. Some people will love it. Right. So going back is to have an idea, have a heading, and then try it.
Yeah, I guess that's the main thing, just actually saying yes to those opportunities. And then when you were talking about leadership before, I guess it's creating psychological safety within the team. And actually we always have these hierarchical structures, which makes then, especially if you're at the bottom of that structure, it feels then kind of scary to reach out to someone who's at the top. But actually, if you kind of embed that kind of more flat structure and you actually get to know everyone and you treat them all the same, it means then they're more likely to respond to your requests and more likely to be open, honest, and their authentic selves ultimately, and provide the best work possible. So I guess, it's a two-way system, but creating that psychological safety is so important.
I had people working for me who were like early 20s. So they're the generation that used to ask questions. They were brilliant. They'd be like, why? Now, I come from a military hierarchy where it's you do what you're told, but they would question it. And I'm really comfortable with that, because I'd rather they know, okay, I can explain more about why we're doing something, if that makes sense. There'll always be generational differences. There'll always be different ways of leadership. But the key is people are your most precious asset. And they don't, it goes, your psychological safety is really key. Create the culture of an open culture. Then people don't bury it if things go wrong. So I would allow people to fail, in a sense that they wouldn't be jumping off the cliff and failing, but they get really close. Because we do learn from our failures. I go back to the point of ruining my A-levels. I learned more from that than I did from anything of successes. And I think it's not that we always fail at something in life. We do. And we don't like it. Yeah. But we learn to accept it. So to allow people, it wasn't about, I didn't care how I looked if they didn't quite do something. But they learned so much. Yes, I can save them from jumping off the cliff. But it's not about us. It's not about my ego. It's not about, it's as a leader, it's about the team. And the other bit also for me is, if someone does a good piece of work, put their name on it. For me, allow them, you do a great piece. You're going to work in hierarchy, you could be the one that diagnoses something, okay, that everyone has missed. And you will find this because you'll be so due diligent when you start. You'll do everything properly and you'll pick up something. My God, make sure that person is known. Yeah, it was them that diagnosed it. And I will tell you now, when you go to hospital medicine, you will have so many different leaders. You'll have those you like. You'll learn how not to do it. Learn from everybody, because I tell you, and none of us are perfect. None of us are perfect at it.
Yeah.
But if there's one thing, I pull the best out. So I will look at people I know, how they lead, and I will generally try and do 2 good points and maybe one I'd do differently. That's how I'd frame it. And I do that with everybody. And you constantly develop your style. So it's good. You guys are gonna be great though.
I'm going to take that. Going to take that from now on, actually, those tips. I guess then coming on, so talking about leadership and your current role now within NATO. For those who don't really know what NATO is, what do NATO actually do? And then what does your role do?
So they're the
NATO?
North Atlantic Treaty Organization. So 32 nations that have collectively signed up. It's like a coalition of defense. So it's working collaboratively and supporting each other. And it's obviously being military, it very much links in with the military side. And it's all about collective defense and supporting each other against any wars or anything, and working together. In a simple terms, that's what I'd probably convey it. Obviously wouldn't let my boss hear that way of answering it, but I think in simple terms for medical. So within defense, you obviously have doctors. We talked about it before. We talked about it in the military. So what do military doctors do? Well, ultimately, to join the military, you have to be fit. So there's a big occupational health part of the military, occupational health. So a lot of it, the military, going back to the military, they take occupational health consultants. Occupational health is another very good career, but people always overlook. But you would be surprised at where that can take you in opportunities in occupational health. There's a lot of space medicine, a lot of aviation medicine, and I've got friends that do the diploma, so they've done the basic GP training, then the diploma in OcComed. So you've got essentially the fit to go. Then you've got what I will call looking after people on a daily basis. So you've got the primary home base, the primary home base, but then you've got looking after people when they go away. So you've got whether you take a GP like I talked about, taking a small group into East Africa, looking after them with extended timelines, or you then face the fact that you're into a conflict organization and then you taking capability because there is no capability. And that could be everything from we call a role 1, which is primary healthcare doctor, all the way back to role 2, which is where you've got damage control surgery, damage control resuscitation, and the basics, fundamentals of surgery. Then you're back to role 3, where you've got more definitive surgery, all the way back to role 4. So we have the way the military works is in a very ordered position. So that's why the military take pretty much most specialties, if not as regulars, as a reserve. So Yasmin, if you did pediatrics and you decided you want to become a reservist, you could become a reservist pediatrician, and they would call on you to look, probably if the military went out, I don't know, to a disaster or humanitarian relief, they could take you with them. So it's that kind of going back. I've gone back to military, but it's that kind of structure. There's a lot you can do within it, all specialities, because essentially you are replicating what you do in your hospitals, but in difficult, demanding, austere environments.
So then within NATO, because it's kind of 32 nations together, coordinating medical planning across 32 nations must be quite complex. So how does that actually translate?
So they
in
have
reality?
standards. There is standards. It's open source. You have NATO standards, and essentially they have a set way of what you run a facility, how you work, and they've collaboratively come up with this way of doing things, and it works really, really well, because it means, if you can think about it, if you were to deploy together, the biggest thing is interoperability. So let's say Martin was working in Cardiff, Yasmin, you were working in London. Could I put you in, let's say you both decided, well, you wanted to be ER, and Martin, let's say I'm going to say you're a surgeon, I'm going to say for now. Let's say I put you into hospital together. Would you be able to operate together? Would you be able to work the same way? Would you have the same protocols? I would suggest you probably would, because but there is subtleties in how you work differently. Yes, you probably would have all done ATLS. Yes, you'd have all done ACLS. So if I called a trauma call, you both would respond pretty much the same. So what's NATO done is it's done exactly the same, but with its setups. So it has ways of standardizing. And the biggest thing of operating when you want to pull in conflict, and it goes the same with humanitarian medicine. Humanitarian medicine had the sphere guidelines. The ability to how you will work because ultimately you become a system, whether it's an earthquake, whether it's a disaster or a conflict. You don't generally work in isolation. You work as part of a network. And that's where the WHO emergency medical team comes in, where you've probably seen UK Med. You've probably come across UK Med as an organisation, which you can all get involved in when you qualify. UK Med, they will have standard protocols, standard training, and they will align with the WHO emergency medical team protocols so that they can send them and then they can fit with other, and you all work off the same principles.
In terms of then your work within NATO, looking at medical planning and defence, what does the future of health and defence look like? Are you kind of forward planning as well?
We do. So you have the immediacy of what's going on now in the here and now, and then you also have the long-term planning. And so I don't know whether you keep up to date with current affairs and world events. So I'll say that again to any doctor. If you are looking at what's coming down, do follow the news, have a look. So for me, we're looking at collaboration, how we work together. So we're looking at if we were to have a war in Europe, how would we respond? What would we do? What do we need? Now, ultimately, there's a priority in life, and especially in the space of conflict. The priority is generally to win the conflict, okay? But medical is a part of what we call the moral component. If you know you have good medical support, psychological support, physical support there, you're going to fight to know that you're going to be looked after. That is a fundamental, important part of supporting people who are going to be potentially in conflict. So we've all lived through COVID, and a lot of us have worked through COVID. And I think you suddenly realise the impact of having essentially the pandemic. And what does it mean? Now, have globally we learned the lessons? You would probably have seen the WHO, who was desperately trying to get nations to sign up, that it would stockpile, it would share information and share. And so health security is one of the biggest things we are probably looking at, but also global warming. So global warming is having a huge impact at the moment on health. So if you look at, I think if I remember, I want to say early this year, normally we run off 2 major and 5 minor world events that WHO are fighting. I think they had something like 5 major and 20 minor. It's been a really, really difficult time. And you've had everything from the earthquakes to flooding. We've had, and then you put onto that the humanitarian crises of, we had migration. All of these are contributing into a global sphere of what's going on. And I think you will become also, I think as a medic, you'll know what you enjoy and what you don't and where you want to be. The reason I say world events is because we can sometimes just spend in our little, we go to work, we work in medicine, we know what's going on in our home, but we don't always see globally. And there can be some opportunities out there to actually go and do something a bit different. I get a lot of people approach me who are just a bit tired. They want a break, they want to do something different. And all they need is change. All they need is change, whether it's to go out and do something for 3 months. Sometimes, naturally, human life is children, family, commitments, financial commitments, can't. But but I think there is opportunities that you've just got to be quite creative to allow it to do it. So if you do want to go to Medicine Sans Frontières for 6 months to work somewhere, or you do want to go out with an NGO, yes, you potentially won't match your salary that you get at home, but the opportunities are there to experience a different life. And I know enough people that change has just, they've come back rejuvenated, if that makes sense, and that sense of purpose. Because we all should have purpose in life and believe in what we're doing. And I know at the moment the National Health Service is in a very difficult situation. Very difficult.
It's one of the things that we really fight for in terms of More Than Medics is, bring back that sort of passion and that drive for impact and change, and doing that in your own way, because we're all different. We all are capable of, massive amounts of impact, but we just, find our forte and what we're good at, where our skills, our
So
talents,
I think
passions, where they
one of my friends was
coalesce.
just working they spent a half a day, they're a GP, but they spent a half a day going to work in a medical centre that was for refugee medicine in London. So they'd just go and spend half a day once every few weeks, and they'd go and do that. So very different patient load, but hugely satisfying. And I think we underestimate what volunteering. I mean, there's a bit of, I don't know if you come across effective altruism as a concept. Have you come across effective altruism? Yeah, you have. Yeah, exactly. And I quite like that movement. I've read their books. And I know they could argue that for us as doctors, that actually to donate our money would have a bigger impact than to donate our time, if that makes sense. So there is an argument that if we gave a day of our wages, they'd have more impact than us spending a day as a doctor. Does that make sense? So effective altruism.
Yeah.
So,
Yeah.
yeah,
surprising.
but because your money can go further. So, but it all comes down to how to define it. Is it doing cataract surgery? Is it going into research? Whereas, let's say, I don't know, let's say your day rate was, just pull it out to the air, as £100. Where's that £100 better spent? Is it you going and delivering care and being a doctor, or is it about using your money? So the reason I say that, though, is that you've got to forget is that volunteering is we are at our happiest generally as humans when we're giving. And I don't know if you've ever done the Yale Wellbeing of Happiness, Science of Wellbeing by Yale. Science of Wellbeing. It's a course online. It's free, and it's about it's all about happiness, and it's by I'll forget her name. She's also got a podcast. It will come to me. I'll get her name for you. But it's things like when you have an ice cream, you love the ice cream. But if you have a second one, it's never quite as satisfying as the first. And it's all about science and how your brain works and what makes you happy. So, for example, I think there was an experiment that married people are probably happier for the first 18 months than single people, but then it evens itself out. So it's also about buying the shoes. You see a pair of shoes, you think you like them. Actually, buying them when you buy them, it actually is not as satisfying as did. But the big thing is giving back is where we are our happiest. So so it's finding those little bits. If you're a medic in hospital and you're struggling, find that little bit of giving that can just bring you that happiness. So I'll get you the name of the course. It's a very famous. It's an online. It's a brilliant little course.
You did a bit of volunteering yourself with the UN Refugee Agency. Could you tell us a bit about the project you did with them?
So to be fair, it wasn't volunteering. I was staff on that one. So but thank you.
Fine.
But no.
But it's that same sort of thing where you're helping and giving back.
So I missed. I obviously left the military. I went into more of a commercial sector, and I missed giving back. So what I was looking at as in this day and age with technology, it goes back to my big sick versus small sick. Do you need to send out capability, such as a doctor, a paramedic, and a bag to support, or can we now look at it remotely? So I'm looking at it's all about risk management. It's all about risk. So somebody like yourself, Yasmin and Martin, your chance of a heart attack are really low. Okay. What's your biggest threat? Well, your threat probably would be a road traffic accident. It might be malaria,
Right.
depending on where you are, if you don't take your antimalarials. Yes, you could get sick, but unlikely, because you're going to do all the precautions. You're going to use bottled water. You're going to wash your hands. You're going to eat food from. So I'm going to limit your thing. But the idea being is, okay, if I sent you out somewhere, could I send you with an app? So could I look at could I give you reach back? Could I give you telemedicine? Would that satisfy? Because ultimately, I want to check you big sick or small sick. So I could, you don't feel well, I'd get you onto a call. It could be an algorithm, could be an app, could be anything. Put your parameters in. If I wanted to, I could send you away with a blood pressure machine. I could send you away with remote monitoring. Science nowadays is incredible. So that's what I was looking at. I was looking at how could we operate globally without having to send a human doctor. So
Interesting. And how do these organizations, because like the UN, NATO, in my mind at least, they're kind of like the same sort of thing. Obviously, NATO maybe a bit more military sort of focus, and UN maybe a bit more diplomacy, is my understanding, and like more politics. How do they work together as a cohesive unit themselves?
So this is where we call civ-mil integration. So civilian and military, a lot of places globally, they will work side by side. And obviously the rules are, generally certain organizations won't because of their impartiality, and absolutely. But a lot of people will rely on military for logistics and support, for visual, speed of asset to arrive. Because if you think about any disaster, there's a local response and there's an international response. And there's a big debate about how do they fit? How do you work collaboratively? You can train together, fine. But there's also, there's committees that will work on civilian military integration where you'll look at, okay, you work off sphere, we work off Stanags. How do we combine the two that we operate collaboratively so that we can all talk the same language? It is amazing to think that we all have our own. You said it to me earlier. You said get out of Dodge. You hadn't heard of Dodge. That to me was a very military term. I literally have used a term that you wouldn't even understand. So you can imagine different organizations having its own language, 3-letter abbreviations, all over. So when you then pull a global workforce in, because the United Nations is global, how then do you get everybody? And it's all about frameworks, standards, and train together. So it's a real. Let's say, for example, Martin, you'll be a GP, let's say, and Yasmin, you're ER. You know your roles, you know responsibilities, you know how you work, but the fundamental there is how can I get you to work together as quickly as I can.
I wanted to also ask, like, because obviously these organizations, that one of the main, I guess, objectives is peace, right? Working with other countries, other organizations, in harmony and not clashing together. Have you overseen or seen any moments in time where, the MOD, the RAF, the UN, NATO have, I guess, put more importance on maybe defense and like geopolitics as opposed to health? Has that ever superseded health?
No, I tell you why. Because medicine is soft power. Okay, so medicine is a very good leveler. Yes, it's not delivering effective conflict. Let's say it's not ammunition. It's not on the front line. But I will tell you now that health is almost cuts through the communication, cuts through the conversation. Health, everyone has health, everyone needs medicine. So it's very much a conversation. So let's say you're in Afghanistan, for example, and you have, ultimately, we treat people in the order to which how sick they are. That's what we are under the Geneva Convention. I think what I'm trying to say is that health is a leveler in conversation. It calms everybody down. Everyone needs it's not offensive. It's not threatening. It's It's supportive.
It's universal,
universal,
in a
correct.
sense. It's something that everyone requires. It's nothing that people can debate about ultimately,
That's exactly it.
I guess.
I like Yasmin. She just
Yeah.
she gets it, doesn't she, Martin? She like
Yeah, I don't know what I'd do without
resilience,
Yasmin, to be
all
honest.
the brilliant words. Thank you so much.
Let's do some quick fire questions, because we wanted to do some. This is something new we
Okay.
wanted to introduce to the podcast.
Yeah.
So some just sort of quick replies. Doesn't have to be that in depth.
Go.
Doesn't have to be
Go
that
for it.
serious either. Okay, let's start.
So,
Okay,
do I go?
do you want to go? Yes, you go.
I'll go. So, what's the most underrated skill for global level medical leadership?
Listening. We should all be listening. Active listening. Top of it, everyone. Listen, don't talk.
Awesome. What's the toughest leadership call you have ever made under pressure?
Sacking someone I liked. I'm not very good at letting people go, but I had to for the safety, and it's never easy breaking bad news that you're letting somebody go. But you have to sometimes. And to be fair, as leaders, you paid to make the big decisions. You're paid to make that, and patient safety comes first. But it doesn't mean it's nice, and you don't get good at it either. It's breaking bad news is never good, and you will be doing a lot of breaking bad news. But breaking bad news and telling somebody that their career is no longer not easy.
What skills helped you the most that you didn't learn in medical school?
Teamwork.
Yeah.
Sport. I love sport. I tell you, I got more out of I probably go back more to my hockey days and support and being part of a team than anything. And it's stuck with me all my life, is being part of a team. So I think yeah.
That's so interesting that your answer to that was teamwork outside of med school, when part of medicine is teamwork. Like,
but honestly, like in med school,
yeah.
this is something I'm quite vocal about. I feel like we're not taught. I think it's not my med school, just med school in general. How to work as a team. We're sort of just we go away, we learn our facts, and we go in and we do our exams. Our OSCEs, our clinical exams, we're by ourselves. You know, we're not really trained. You know, in actually the act of working as a team.
I would love to see you guys do
together.
some, and to be fair, it's coming into your curriculum. I know it is, because I spoke to the Faculty of Medical Leadership. They are looking at leadership training in medical schools, because I think if we get you now and you get you interested, and then you follow through, and it could be you go, I fancy doing a fellowship in medical leadership. I mean, that is a very good fellowship. Australia do a phenomenal course. UK are doing a course, and it could be you fancy being a medical director and you've already got the leadership skills. There is some of you who will qualify, who'll go, actually, I want to be chief exec of a hospital. So why not start early? Do the leadership fellowship, do a master's in leadership, or something a bit different. So take the opportunity. So yeah, there you go.
Awesome.
In 3 words, can you summarize the impact that you've had with your diverse career?
Failed, but won.
I love that. I didn't expect that, wouldn't it?
Failed, but won. I think we play the game in life, okay, where we're going up and down and we're on a roller coaster. But actually, when you get you above your life and you look, you're actually like, oh, actually, it's been okay. You felt it. You know, every failure, every success, every time you spoke to a patient, didn't do quite so well in how you communicated, every time you wished you'd reflected, you'd done it better, broke bad news, every time you wish you hadn't done what you did, when you do get above it and you look back, you generally are doing okay. And it's just remembering that. Remember to get above your life, because you're living it like this on your roller coaster. Just get above it occasionally and go, actually, I'm doing okay.
Yeah. And what's I guess, leading on from that, what's the impact that you yourself would have want to have had at the end of your career?
So I tell you, so my father died screaming in pain. My father had cancer, and I was a medical student. I was like you, and I was called home to say goodbye. And I'll tell you this quick story. So his pain relief, they were not on top of his pain relief. There was no space in the hospice, so he's at home. And I'd done my placement with palliative care, so I knew all about how death was it was green towels, very relaxed, very, wonderful, peaceful, and off they go. And he was really agitated and he was really, really unhappy. And the doctor came, and they gave him, I think it was just essentially 10 milligrams of morphine as a one-off. I mean, it was totally not going to touch him. And even I knew that. And they upped the syringe driver, they upped the fentanyl patch. And I knew fentanyl patch was going to take a time. But when you're a student, okay, you don't feel you have a voice. You have the basic knowledge, you half there, but you quite. Anyway, to cut a long story short, he was very agitated, unhappy with us, and got up. And the action of getting up, he died there. And I will tell you, I blamed myself for the pain for years. So when I go back to my medical career, I will tell you, I started hating doctors. I have to say I did not want to become a doctor because essentially in my mind, the most important person in my life, they'd just let down. And for the first time, I saw that medicine is not perfect. We're human, okay? And it probably took me a good 5-6 years to accept that. So you then go in your house officer years, I'm doing, and okay, I was probably one of the best, doctors. I mean, my patients were like, I'd check in the middle of the night were they still alive. I mean, I used to phone up from saying, yeah, Cat, still alive. Oh, thanks, good, cool. Because I literally had seen someone die, and I was like, no patient is ever going to die in pain, having seen that. And you will have little stories like this in your life that will shape you as a doctor. You will learn. And so in answer to your question, and I can't remember the original question because I completely lost the original question.
No, what's the impact you would have wanted to have made?
I wish I could have, for him, done better. However, when my mum then died, she had a phenomenal death. I mean, you're a doctor, so they involved me. I had a professor that was looking after her. He was like, this is your mum's numbers. Is any idea? I mean, I was a GP, but they still involved me with everything. And that was wonderful because all of a sudden it was a very good death because I felt I had supported and done everything I could. So the impact I had is probably on my loved ones and the support. We all do medicine for different reasons. You'll all have friends that will go, Yasmin, can you just help me out with this? Can you just do that? They'll expect you to give free medical advice. And I used to say, no, I'm sorry, I've had a drink. Surgery's not open today. But you do help each other and you do help your friends, and it's natural that you will. So I think the key for me is just being there for others, being there when they need you. The friend that phones up because their father has just been diagnosed, the friend whose daughter's not quite right, obviously go and see a professional, but you will have this. It will impact every part of your life. It really will. But if it's not for you, it's absolutely fine. It's a vocation, but also it's a job. So if you actually, for those people that find 5 years in, they're really unhappy, don't slog at doing something unhappy. Take the skills that you've learned, the ability to take to differential diagnoses, balance risk, manage multiple inputs, work crazy hours, build your resilience. Skill. Companies will take you. Anyway, there we go.
Yeah.
No, I'm so sorry to hear that experience you had with your father. But I think a redeeming thing is that you've let that shape you and shape how you act now on a daily basis. You are that much more caring. You're that much more receptive to your patients because you really understand what they're going through because you've seen it firsthand yourself with your father. And so I think you've translated that into something so beautiful. And day in,
you'll
day
be
out,
the same. You will be the same because life, you will see it and you will. And I think I go back to the term active listening. If there's one thing I can instill in people from a leadership perspective, is to actively listen. We do a lot of talking when we're leading, and actually to listen. And I say that in Humanitarian that when you're arriving in a situation, when you've got multiple actors all doing different things, craziness, and you need to bring some calm and some still, listen. listen to what's going on, and then react. And that will be the same when you are. It's the same when you'll be the doctor, head on fire, called to a ward. Oh, especially at the beginning, and just listen to what the nurses have to say, because your brain's going, "Oh my God, what do I remember?" And it's like, "Okay, I'm listening.
Yeah.
I'm listening." Anyway,
Yeah.
all good.
So, if a medical student or resident doctor is listening, I'm thinking, wow, Dr. Cat Davison, she's worked for the RAF as a medical officer. She's worked with NATO. She's worked with the UN. She's done humanitarian missions. She's done expedition missions. She's done it all. This is all really cool. This is amazing. But how do I actually get started? What would you say to that?
So I would try things. Okay. So I would, we have this expectation in life, and sometimes you have to take the expectation off and you have to try. So it goes back to my basics. If you know what you want to be professionally, work toward that professionally, but see if you can create time and space to do some other bits. So what did I talk about? Diploma in Trop Med, Masters in Public Health. Go to World Extreme Medicine Conference, go to your conferences, go to conferences where you get to meet different people. There is other conferences out there, but go where you can absolutely meet different people from different backgrounds and hear their stories and their journeys. So get out there and trial it. Now, I'll tell you, one type of humanitarian, they're not all the same. So it could be that you like infectious diseases, or it could be that actually what you really like is humanitarian response. You like actually doing the emergency medicine in difficult environment, and actually you don't really like the infectious. We're all different. So try and work out what you like.
Yeah. Just get stuck in. And don't be afraid to fail.
Don't be afraid to fail. And don't be afraid that it's not going to be perfect. Because in that environment, nobody is. But you get better at planning, preparation. I'll tell you, every time you go out the door on an expedition or a short term, a support, you get better and better. You do. And even if it's the UK and you volunteer to go and support a race, London Marathon, or volunteer to go and support, I don't know, a festival in their medical team, I will tell you, doing medical support for a festival is pretty crazy, because ultimately you are in a field environment. It's not your natural habitat. Yes, you do have emergency services close by, but you've got to make a decision. So get used to doing medicine in difficult places. And goes back to my final was about write a report, be really due diligent, don't complain. I used to say to my juniors, if you're going to complain, they'll go, nah, don't want to use that person. If you're going to have a million caveats about why you can't do something, but if you person put their hand up and say, yeah, I'll do it for you. Yeah, I'll help set up the tent. Yeah, I'll help check all the kit. I'll help put it all back. It goes a long way. It really does. Because part of the team goes back to big team. And have to say, we talk about medicine and different roles and how you fit in the hierarchy of hospital medicine and where you fit and you build it up. When you're out of the outer environment, you're all equal. You're all equal. And you all have responsibility to look after that patient, to look after each other, and also to work. And that's the bit I love, because it is a proper team. And I'm not saying, to be fair, hospital medicine is a team, but it's a very structured team. You put yourself out. So yeah, go and try it. Enjoy it. And don't be afraid also, if you think you like something and it doesn't work out, change. So to all of you that start in ER, Yasmin, if in 3 years' time you go, actually, I think I wish I had been a GP, that's all good. All good.
You probably will end up, transitioning after.
No, I think good career. It's a good career. Anyway.
Thank you so much, Kat, for all your, so many golden nuggets in this. I was literally writing down as you were speaking, the main
what's
key
your final
points.
question, Yasmin? Because you haven't asked it. You've got one more question left. What was it?
Well, my final question was actually, so to inspire more people and get more people on the podcast, which people would you recommend for us to invite for the next podcast?
Okay, so Spaceman Pete. Spaceman Pete.
Spaceman Pete.
He's Professor.
Not Dr. Pete.
Awesome
Spaceman
Pete. Dr. Pete. He's literally just setting up an astronaut suit lab. He's got PhDs and opportunity. He's just brilliant, and he's bringing space to the masses. So he is definitely one of my people, because He will show you how you can take a passion and turn it into a job.
Thank you so much for today, for the conversation. Honestly, it's probably been one of my favorite conversations
Good, you enjoyed it.
thus
Thanks.
far.